So, very good evening to all. Hope my voice is audible and my screen is visible. So, I think we would have completed all the renal masses and renal tumors, and then bladder injury, urethra injury. Then we have discussed about the urethral stones, everything we have discussed. And today we are going to move towards a very fantastic topic, testicular mass. So a probable mistake that as undergraduate, which I did, which you did, and everyone do is, we will be reading every topic in the testes separately. But unfortunately, all the testicular topics are going to be grouped together as testicular mass. Okay, everything is going to be grouped into single one called as testicular mass. So, what is a testicular mass? Anything, any mass that is going to be because of a testis. Okay, because of testis, any mass, we are going to call it as testicular mass, and it can be due to three causes. Either it can be absent testis, either it can present as absent testis, or it is going to be present as painless scrotal swelling, or it is going to be a acute scrotum. What is the difference between them? One is not having testis itself. The other is going to be a painless scrotal swelling. And the third one is acute scrotum. So today we are going to discuss these three headings separately. First one is a absent testis. Second one is a painless scrotal swelling. Third is a acute scrotum. So just put a heading as absent testis. Now what happens? Now you are going to be posted in a pediatric ward and you are just with the baby. You are just for in the labor and baby is delivered. And once the baby is delivered, preliminary examination of the baby is being done. And once you do the preliminary examination of the baby, you find that the testis is absent. So there is a absent testis. Okay, in the newborn. What will be your next step? Anyone, can you put in the chat box? So you're just finding a baby without testis, guys. What will be your next step? What are you going to do? You're going to perform a clinical examination. When you're going to perform a clinical examination, you find that there is a non-palpable hemiscrotum. There is a non-palpable hemiscrotum. Why do I call it as hemiscrotum? I call it as hemiscrotum because of the absence of rugosity. There is absence of rugosity. Okay, ma? So there is absence of rugosity. There is going to be non-palpable scrotum. Now what you're going to do? Immediately. Can you tell me what will be your next step? Will you take a scan and will you start locating the testes and you do surgery to bring back the testes to the scrotum? Will you do that in the newborn baby? No. So what you're going to do is you're going to wait for 6 months. So what you're going to do, you have to wait for 6 months. You have to wait for 6 months. After 6 months, okay, you're going to again ask the patient to come to your clinic. You are a pediatric surgeon. Okay, you are a pediatric surgeon and you are having your own clinic setup or your hospital. You are sitting in the OP. Now the patient is going to come back with the baby. And what you're going to do now? You're going to perform a clinical examination. So you're going to perform a clinical examination. What you're going to see? You're going to see whether the testis has come back to the original position. Where should be a testis be? Inside your scrotum. So you're going to see whether the testis came back to the scrotum. If the testis is present in the scrotum, very well, no problem. You have successfully, without treating the patient, you have cured the patient. So now the patient is very normal. The testis came back to the scrotum, so no issues. But now the testis is not in the scrotum. It is not in the scrotum, but it is present in palpable. It is palpable in the inguinal canal. It is palpable in the inguinal canal. What will you do? It is palpable in the inguinal canal. That means it is going to be a incomplete descent of testes. So this is going to be a incomplete descent. Incomplete descent of testes. Descent of testes. Okay. So it is an incomplete descent of testes. Now what you will do? That is second scenario. Third scenario is a worse one where you cannot see your testis in the scrotum. Okay, you cannot see scrotumல testis பார்க்க முடியல and it is not palpable also. It is not palpable elsewhere. It is not palpable even in your abdominal examination. Now what you will do? So you have three scenarios now. If it is palpable in the scrotum, so you don't need to do anything. No intervention required. No intervention required. The baby is fine. Now, the testis is not in the scrotum, but it is present. It is palpable in the inguinal canal. What will be your next step of management? You're going to go for a inguinal exploration. You're going to go for an inguinal exploration. Okay, you're going to go for an inguinal exploration that is called as orchiopexy. You're going to do a procedure called as orchiopexy. Now, non-palpable. Your testis is non-palpable. You're going to perform a abdominal examination. Not palpable. Now, what you're going to do? Maybe the baby is very conscious that sometimes in the consciousness, you cannot palpate very well because baby is going to cry, right? 6-month baby. நீங்க examination பண்ணும்போது சும்மா இருப்பாங்களா? கண்டிப்பா இருக்க மாட்டாங்க. So, they will be like crying and they will not allow you to palpate and check. So, what you're going to do is, now, in the next step, you're going to completely general anesthetize the patient. So, under general anesthesia, you're going to examine the patient. And while examining, now you are able to palpate in the inguinal canal. So, then you're going to term it as an incomplete descent of testis. But now also, it is not palpable. Even now, you cannot palpate. What you're going to do? You're going to go for a laparoscopy. You're going to perform a laparoscopy and you're going to see. Okay, laparoscopy பண்றீங்க. Laparoscopy பண்றப்போ 3 type of end results நமக்கு வரலாம். Okay, 3 end results we can get. Number 1 is going to be, you can find testicular vessels. Testicular vessels are found. In the external inguinal canal, it does not yet get inserted into the inguinal canal itself. Inguinal canal குள்ளேயே வரல. அது வெளியே தான் இருக்கு. External inguinal canal ஓட entrance-லயே தான் இருக்கு. அப்ப நீங்க என்ன பண்றீங்கன்னா, you're going to perform a inguinal exploration. You're going to perform a inguinal exploration, that is orchiopexy. Okay, va? Now, second scenario is, your testis is, it's going to be palpable. It is going to be visualized in the deep inguinal ring. So, it is higher up from deep ring. It is higher up from deep ring. Since it is higher up from deep ring, so what you're going to do? You're going to do orchiopexy only. Again, you're going to perform orchiopexy, but this is going to be two-staged orchiopexy. This two-staged orchiopexy, you call it as Stephen Fowler orchidopexy. Please write it down, guys. I'll explain you everything. Okay, please write it down, whatever I'm writing. See, this is all going to be a shorter form of whatever given in your textbook. So உங்க textbookல Bailey and Lowல இருக்கிறத நான் ஷார்ட் பண்ணியிருக்கேன். ஒரு டேப்லோ காலமா போட்டிருக்கேன், ஒரு ஃப்ளோ சார்ட்ஸா போட்டிருக்கேன், அவ்வளவுதான். ஸோ இதை நீங்க எழுதியிருந்தீங்கன்னா தியரி புக்கை படிக்கும் போது இந்த ஃப்ளோ சார்ட்ஸை நீங்க ரெஃபர் பண்ணீங்கன்னா போதும், you can understand it very well. Okay, so now the third one, if now you are going to perform a laparoscopy, but laparoscopy பண்றப்ப என்ன பண்ணுவீங்கப்பா பேசிக்கா? நீங்க அந்த டெஸ்டிஸ் வந்து குபர்னாக்குலம் டெஸ்டிஸ் வழியா, so அது வந்து superficial inguinal ring, inguinal canal, deep inguinal ring, அதுக்கப்புறம் it is going to enter into the scrotum, right? So deep inguinal ring, superficial inguinal ring, inguinal canal, இதெல்லாம் பாஸ் பண்ணி அந்த ஸ்க்ராட்டம்க்கு வருது இல்ல, அந்த பாத்வேவை நீங்க ட்ரேஸ் பண்றீங்க. ஸோ அந்த பாத்வேவை ட்ரேஸ் பண்ணி you're just trying to see whether your testis is present or not. But unfortunately, so the tube is going to be ending blindly. உங்க பாத் வந்து பிளைண்டா இருக்கு, அதாவது you cannot find the testis. அப்படின்னா you term it as a absent testis. You're going to term it as absent testis. First சொன்ன absent testis பிறக்கல, குழந்தைக்கு இல்லைன்னு நம்ம சொன்னோம். இப்ப அந்த 6 monthsக்கு அப்புறம் செக் பண்றப்ப கூட அந்த பாப்பாக்கு இல்ல, அந்த பாப்பாக்கு you cannot find the testis. Now the next question I want from you guys, do you want me to tell about the descent of testis in detail? Can you put in the chat box if you want to tell the descent of testis? Anatomy, அது பேசிக்கா anatomy, embryology, again உங்க physiology எல்லாமே கலந்து வரும். But if you want, I will explain. Otherwise, I don't want to explain you guys. So the descent of testis, that anatomy, do you want me to explain? Or is it fine? This is enough. எந்த மந்த்ல எந்த இடத்துல இருக்கும் அப்படின்னு எல்லாருக்கும் தெரியுமா? 6 months la enga irukum? 6 months of gestational period la, where it will be? Anyone? 6 months of period of gestation la, where will your testis be? It will be in the iliac fossa. Write it down. So it is going to be in the iliac fossa. Then at 7 months, what happens? Your testis is going to be in the inguinal canal. Inguinal canal. And at 9 months, what happens? It is going to exit through the superficial inguinal ring. Superficial inguinal ring. Superficial inguinal ring. And what happens at 9 months? Okay, at the end of 9 months, okay, end of 9 months, what happens? It is going to enter into the scrotum. So this is what normally in every baby occurs. அதனால தான் நான் என்ன சொல்றேன், maximum number of peopleக்கு நீங்க டெலிவர் பண்றப்பயே testis will be in the scrotum. But unfortunately, if testis is not in the scrotum, please don't worry. Wait for 6 months. Then you're going to start your examination. 6 months அப்புறம் தான் நீங்க உங்களோட differential diagnosis, உங்க மூளை எல்லாத்தையுமே நீங்க யோசிக்க போறீங்க. ஓகேவா? 9 monthsல தான் you're going to have this scrotum. So can you tell me what actually forms your testis? அந்த testis வந்து 6 monthsல gestational periodல iliac fossa வரதுக்கு முன்னாடி எங்க இருக்கும்? It is going to be from the retroperitoneum. So it is a retroperitoneal origin. Retroperitoneal origin from the your genital ridges. அப்ப இந்த process நடக்கிறதுக்கு யாரோ help பண்ணணும்ல? Who is helping? Who is going to act as a trigger? First and most important trigger is going to be differential growth. Differential growth of abdominal wall. Abdominal wall. That is going to be acting as a main one. Then comes your hormone. Number 2. Number 3 is going to be least contribution is gubernaculum. ஆனா நம்ம எல்லாருமே என்ன படிக்கிறோம் அப்படின்னா, gubernaculum தான் most common cause for the descent of testis அப்படின்னு படிக்கிறோம். சத்தியமா இல்ல. Gubernaculum is a least contribution. I want you all to note it down. Gubernaculum is a least contribution. Least contribution for the triggering of the descent of testis. Clear? So now, if there is going to be undescent testis, if there is going to be undescent testis, where will your testis be? Where will your testis be? எங்கெல்லாம் இருக்கலாம் உங்க testis? It is going to be along the path of the testis. அவ்வளவுதான். So உங்களோட deep inguinal ring, inguinal canal, superficial inguinal ring, இங்க தான் இருக்க முடியும் உங்களோட testis. வேற எங்கேயும் போகாது. கவலைப்பட வேணாம். So என்ன ப்ராப்ளம் அப்புறம்? சரி, அங்க இருந்துட்டு போட்டுமே. யோசிச்சிருக்கீங்களா இன்னைக்காவது? Let it be there in the inguinal canal. Let it be there in the superficial ring. Let it be in the deep ring. Why do you want your testis to be inside the scrotum? Why do you want? Anyone? Can you put in the chat box? Why do you want your testis to be inside the scrotum? Why don't the testis be inside the inguinal canal? Probably you will have a swelling like your hernia. That's all right. Apart from that, what do you have? What is the problem you will get? Have you ever thought? Write it down. So, if your testis is present in the inguinal canal, if it is present in inguinal canal, kandipa there is a problem. It is not the physiological site of your testis. Therefore, what it does? It is going to reduce in the volume. Number 1. Number 2, there is a increased risk of intratubular germ cell neoplasm. Intratubular germ cell neoplasm, ITGCN. Intratubular germ cell neoplasm. That is going to be the second point. Third point, you have to remember that your Sertoli cells are most affected. So, your Sertoli cells gets insulted. நீ இங்க என்னோட இடத்துல இருக்க வேண்டியவனே இல்ல, நீ ஏன் இங்க இருக்க? So நம்ம you have seen your in the previous movies and all. So like there will be a fight, right? So when intruder comes and stays with the family, now what the family will do? Family will try to just send them out. So our love marriage pani or girl comes to the house, then what the family members of the house do? So they will be always in a fight, right? Same way, your inguinal canal, the people inside your inguinal canal, they are fighting. You are an intruder. Why are you sitting here? அப்படின்னு கேக்குறாங்க. அவன் கேக்குறப்ப என்ன ஆகுறான்? அந்த Sertoli cells insult ஆகுறான். Sertoli cells இன்னொரு செல் என்ன இருக்கு? Testisல. You also have Leydig cells, right? Sertoli cells Leydig cells. Adela Sertoli cells are the one who is going to get affected more. He is going to be affected more. Okay, va? So adanala Sertoli cells enna pannadhu, Leydig cell enna pannadhu. Do you know that? Sertoli cells are going to perform very, very important for life, guys. Spermatogenesis. It is going to be the one who performs spermatogenesis. Now, just imagine Sertoli cells getting insulted. And what Sertoli cells is doing? So it is slowly moving into a depression. And what happens because of that? The spermatogenesis is getting affected. Spermatogenesis is getting affected. Is it clear? So now the spermatogenesis is getting affected. And what about your Leydig cells? Leydig cells? Okay. அவன் வந்து எப்படின்னா ஓகே இன்சல்ட் பண்றீங்களா பண்ணுங்க அப்படின்னு கொஞ்சம் கொஞ்சமா இஸ் லைக் டாலரேட்டிங் தம். பட் டு யூ திங்க் ஈவன் தோ இஸ் டாலரேட்டிங் தேர் பி ஸ்லைட் ஃபீலிங் ரைட் இதே ஆர் இன்சல்ட்டிங் மீ அப்படின்ட்டு. ஸோ இருந்தாலும் நார்மல் டெஸ்டோஸ்டிரான் லெவல் மெயின்டைன் பண்றோம். நார்மல் டெஸ்டோஸ்டிரான் லெவல் மெயின்டைன் பண்றோம். சின்ஸ் இஸ் மெயின்டைனிங் த நார்மல் டெஸ்டோஸ்டிரான் லெவல், since he is maintaining normal testosterone level, there is going to be normal secondary sexual features. Normal secondary sexual features. That is the important point I wanted you all to remember here. Now, there is going to be a undescended testis, which is presenting in the intestinal, it's presenting in the inguinal canal. I'm sorry. It is presented in the inguinal canal, or it is going to be present above your superficial inguinal ring, or it is going to be present above your deep inguinal ring into the abdomen. Now, what might be the complication it is going to face? What I am going to discuss, right? Can you understand? Are you all with me? So now what I am asking is, what is going to be the complication of undescended testis? Write down. Complication of undescended testis. Please write it down. Complication of undescended testis. So what are the complication of undescended testis? TES, TIS, testis. Remember the mnemonic, easy, right? So please don't make mnemonic that is irrelevant to the topic. So this I always say. Make mnemonic that is relevant to the topic so that you will remember. Or mnemonic concept understand பண்ணிட்டு போங்க. So என்ன concept? So நான் mnemonic-ம் கொடுக்கிறேன், concept-ம் நான் சொல்றேன். So let me you tell me guys. So spermatogenesis is not going to occur. If spermatogenesis is not going to occur, what is going to be the problem? Sperm is not going to be produced. If that person is not getting himself treated, testis is going to be present inside the inguinal canal itself. When it is present in the inguinal canal itself, what happens? Spermatogenesis is going to be affected. So what happens? The person is going to become sterile. So idala S stands for sterility. S stands for sterility. Now, if the testis is present in the inguinal canal, what happens? Your body will be starting to insult them. I told you, right? So what is that called as? When our body insults any foreign agent, we call it as inflammation. So how do we represent inflammation? Itis. So this is epidermoorchitis. So it is going to cause epidermoorchitis. Epidermoorchitis. Okay. Now, your testis is going to be present in the superficial ring. It is going to be present in the inguinal canal, or it is going to be present in the deep ring. Are they prone for trauma, right? Yes. So they are prone for trauma. They are present very superficial. உங்க scrotum அவனை பத்திரமா பார்த்துட்டு இருக்காங்க. அவனை உள்ள வச்சு திடீர்னு என்ன பண்றீங்க நீங்க? அந்த இவனை வந்து சூப்பர்ஃபிஷியலா விடுறீங்க. சூப்பர்ஃபிஷியலா விட்டா அவன் இன்ஜூர் ஆகிறதுக்கான சான்ஸ் நிறைய இருக்குல்ல. ஸோ அதனால trauma is one point. And they are going to be also causing indirect inguinal hernia because they are present inside, right? Your inguinal canal. They are going to cause indirect inguinal hernia. Inguinal hernia. And so when there is going to be your testis is going to present with all your, what are the things that are going to be present along with testis, guys? So you're going to have testicular artery, right? You're going to have testicular artery, along with testicular artery, and vein is going to be there. Okay, so all those bundle, I call it as bundle. So what is the testicular bundle going to be consisting of? Your testicular bundle is going to consist of what? Anyone, can you tell me? What does your testicular bundle consisting of? Come on guys, you know that. So we call it as papiniform plexus, right? Your papiniform plexus. Papaniform plexus is going to be the testicular artery and testicular vein bundle that is going to be supplying your, yes, that is going to supply your testis, right? So the artery which is going to be running along with that, you will also have your vein, okay? And all those things are going to be coming together, right? So that is going to be coming together, right? Now what happens is they undergo torsion. They might undergo torsion. So that is also one complication. And when any நம்மளோட பாடியில ஒரு பெரிய ப்ராப்ளம் என்னன்னா, ஏதோ ஒரு ஆர்கன் அதுக்கு சம்பந்தம் இல்லாத வேற ஒரு இடத்துல இருந்ததுன்னா அதால அட்ஜஸ்ட் பண்ண முடியாது. ஸோ அப்ப என்ன பண்ணும் கொஞ்சம் கொஞ்சமா, இட் வில் பி லைக் ஃபர்ஸ்ட் இட் வில் பி தேர், இட் வில் பி ட்ரையிங் டு ரெசிஸ்ட். பட் கொஞ்ச நாள் கழிச்சு என்ன ஆகும்னா, அந்த இடத்துக்கு ஏற்ற மாதிரி தன்னை அட்ஜஸ்ட் பண்ணிக்க ட்ரை பண்ண ஆரம்பிக்கும். அப்ப நம்ம நார்மலா, do you remember I have given when you would have read in your pathology Robin's first chapter, second chapter probably, okay? So you have your cell injury and cellular adaptation, right? So what happens in a person who is smoking? In a person who is smoking, what happens? So you have a squamous epithelium. That squamous epithelium is going to convert into columnar epithelium, right? Sorry, smoke பண்றவங்க columnar epithelium, okay? Squamous epithelium வந்து columnar epithelium யாருக்கு வரும்? GERD patient, esophagus-ல. So that will be one example. Similarly, for smoking patient, you would have read that that columnar epithelium of nasopharynx getting converted into squamous, right? So அந்த மாதிரி you would have read, right? So அந்த மாதிரி நம்மளோட testis என்ன பண்ணும்னா கொஞ்சம் கொஞ்சமா they become metaplastic in nature. So they are going to give dysplasia, metaplastic, and they are going to finally what happen? They are going to undergo cancer, tumorous condition, malignancy. So what is the malignancy which commonly occurs here? Seminoma. So these are the complications. Now will you forget? So testis in which ஒன்னொன்னா மனப்பாடம் பண்றதுக்கு ரிமெம்பர் டெஸ்டிஸ் அப்படின்னு நான் வச்சுக்கோங்க இந்த நிமோனிக்கா. பட் வேற என்னெல்லாம் வரலாம் அப்படின்னு உங்க மைண்டை கிண்டில் பண்ணுங்க. யூ வில் கெட் த காம்ப்ளிகேஷன். ஓகே கைஸ், ஸோ தட்ஸ் ஈஸி ரைட்? Have you all got it? That's easy, right? Any doubt? Any doubt till now? Okay. So now what happens is, now there is an incomplete descent of testis. It leads to infertility in sonella. Can you tell me what is the fertility reduction after orchidopexy for cryptorchidism? So இது வந்து நீட் பிஜில இப்பெல்லாம் இந்த மாதிரி கொஸ்டின் கேட்குறோம். ஒரு இனிஷியல் கொஞ்சம் ஹையர் எண்டா. ஸோ நம்ம முன்னாடிலாம் என்ன பண்ணோம், இன்ஃபர்டிலிட்டிக்குரிய காஸ் வந்து அன்டிசெண்டட் டெஸ்டிஸ்னு சொன்னோம். இப்போ அவன் என்ன கேட்குறான்னா, ஸோ ரைட் இட் டவுன் புட்டிங் அ ஸ்டார், fertility reduction after orchidopexy, for cryptorchidism is actually 38%. இதை வந்து கொஸ்டினா கேட்டு வச்சோம். ஸோ இதெல்லாம் நீங்க வந்து ஒரு சின்ன டேபிள், சின்ன நம்பர்ஸ் வந்து உங்களோட பில்லியன் லெவல்ல இருக்கும். பட் இதை கொஸ்டினா கேட்டு வைக்கிறோம். ஸோ I will just try to add on all the previous year NEET questions through my topics. So நீங்க அதை அட்டென்ட் பண்ணீங்கன்னா ஃபியூச்சர்ல நீட் பிஜி எக்ஸாம் எழுதுறதுக்கு கூட it will be useful for you. So men with undescended testes will have a reduced fertility even after orchidopexy. Orchidopexy பண்ணாலும் fertility வந்து 38% கிட்ட reduced ஆதான் இருக்கும். Bilateral cases who are operated as adults are almost infertile தான். அவங்களை நீங்க ஆப்ரேட் பண்ணா கூட they will be remaining infertile only. So what is the recommendation is, always go for early surgery because degeneration of spermatogenic tissues and reduces count after second year of line on treatment. So நீங்க untreated வச்சு நீங்க 2 years அப்புறம் நீங்க ட்ரீட் பண்ணீங்கன்னா அந்த செல்ஸ் எல்லாம் செத்து போயிடும். அதுக்கப்புறம் நீங்க புதுசா கிரியேட் பண்ண முடியாது. அதனால எவ்வளோ ஏர்லியா டயக்னோஸ் பண்ணி ட்ரீட் பண்றோமோ தட் இஸ் அவ்வளோ நல்லது. சிமிலர்லி செமினோமா, okay, so risk of cancer is 2 to 3 times higher than the general population. Similarly, in the orchidopexy, if it is going to be done after puberty, 5 to 6 times. So அதனால before puberty இதை diagnose பண்ணி ட்ரீட் பண்ண வேணும். ஓகேங்களா? ஸோ அதனால தான் நம்ம இப்பயே ப்ரோட்டோகால் சொல்றோம். ஒரு pediatric surgeon or surgeon or a pediatrician, if you're going to see your patient having undescended testes, you need to give a guidelines for them. You need to operate them. So first 6 months பண்ண முடியாது. ஓகே, பட் என்ன பண்ணலாம்? ஸோ அதுக்கப்புறம் நம்ம பண்ண சொல்லலாம். ஸோ அதுக்கு தான் நான் வந்து உங்களுக்கு I have given the protocol. So you have to perform a Stephen Fowler orchidopexy, okay, or you can go for inguinal exploration if it is found in the inguinal canal. Clear, right? Any doubt? Seminoma is most common, but there is other chances of other cancers also is possible, but most common is going to be seminoma. Clear, right? So management of undescended testis, any doubt? Do you have any doubt? What is the surgery name? Can you put in the chat box? What is the surgery name? What is the orchidopexy done here? Fowler-Stephens orchidopexy. It can be either open or a laparoscopy. That is not a problem. Now, sir, orchidopexy. So, it is a maneuver that is done to help to gain length. So, we have process vaginalis. So, you need to identify the separated and you need to ligate them. So, your covering of the spermatic cord should be divided and lateral fibrous band just inside the internal ring should be divided. So, this is going to be the procedure that is done in orchidopexy. Very good, Lavanya, for answering. It is Stephen Fowler, orchidopexy. Okay, very good. So, now let's move into the next one. Okay, so I told you that what is the T stands for? First T stands for, that is going to be your testicular torsion. How do the patient comes to you guys? In testicular torsion, so in the moon condition oda dhaan varuvanga patient. Testis la endha problem vandalum in the moon category la nama divide pannalam. Can you tell me torsion endha category la varum? In the moon set of categories la torsion comes into which category? Can you tell me? Can you tell me? Torsion comes in which category? It is going to come under acute scrotum. So now we are going to start discussing acute scrotum. Put the heading as acute scrotum. Under acute scrotum, we have two important conditions. Just two conditions. One is going to be your testicular torsion. Testicular torsion. And other is going to be your epidermo orchitis. Epidermo-orchitis. So you have testicular torsion and you have epidermo-orchitis. Testicular torsion, it is going to be sudden onset. So we will compare and study. So how is your testicular torsion going to be? Testicular torsion is going to be a sudden onset. Sudden onset. Whereas your epidermo-orchitis, it is going to be gradual onset. Gradual onset. So sudden onset in sonna ஏதோ ஒரு trigger factor இருக்கணும். Correct? Are you all agreeing with me? If I am going to tell it as a sudden torsion or sudden onset, there must be some triggering factor. What is going to be the triggering factor here? It may be exercise. It might be cold condition. All these are going to cause sudden torsion. But remember, don't always expect it to be sudden onset. Rarely, it can also be gradual. So, gradual, rarely. This is what I wanted to tell you. The recent Bailey tells that it is gradual, rarely. Okay. முன்னாடிலாம் நம்ம ஃபுல்லாவே இது சடன் ஆன்செட்னு சொன்னோம். இப்போ அது gradual, rarelyன்னு சொல்றாங்க. Plus, you have to remember, fever is not a compulsory condition. Fever may be there or fever may not be there. Okay, va? Sudden, ana in the side la pathina, what is going to be the symptoms or a clinical features? What are the clinical features you're going to see? Number one, there is going to be increased frequency of micturition. There is going to be increased frequency of micturition. There is going to be dysuria. There is going to be dysuria. Now, fever, yes, of course, fever will be present. And now you're going to perform examination. So, testicular torsion on examination, what you're going to see is, so they will be lying eye up and higher up. So, higher up position la irukom. It will be horizontal. Cord is going to be short. And your cremasteric reflex will be positive. Cremasteric reflex will be positive. So, this is a very, very important point to differentiate between the testicular torsion and epidermo-orchitis. Epidermo-orchitis. See, this is going to lie normal position. Okay, and they are going to be very normal. And only thing you can see is cord is going to be thickened. That's all. And cremasteric reflex is negative here. Understood? Cremasteric reflex is negative here. Now, on elevation of testis, now what you're going to do? You're going to do pre-hands technique. Pre-hands technique. What are you going to do? You're going to just, what you're going to do is, you're just going to elevate the testis. Elevate the testis. On elevation of testis, what happens is the pain gets aggravated. Pain gets aggravated. Then it is going to be your torsion. Same thing if you're going to do here, the pain is going to get relieved. Pain is going to get relieved. Then it is going to be your epidermoarthritis. So you have testicular torsion, you might have epidermoarthritis, and that is going to be your pre-hands test. Any doubt? Okay. Now I am done. I have done my pre-hands test. I have done all my tests. So there is going to be a Drenmach sign. Testis lie at the anterior level. So அதுக்கும் ஒரு sign name இருக்கு. எல்லாமே நான் பண்ணி பார்க்குறேன். ஸோ இது ஒரு யங் மேல் acute scrotal pain and swelling கூட வராங்கன்னா I have to know how to differentiate between a torsion and epidermoarthritis. So torsion, so usually 720-degree twist இருக்கும். This causes a rapid ischemia and sometimes 360-degree shifts கூட இருக்கும். If testis can be untwisted within 6 hours of torsion, there is nearly 100% chance of salvage as compared to 20% if surgery is delayed by 24 hours. ஸோ நீங்க as soon as possible நீங்க பண்ணீங்கன்னா 100% டெஸ்டிஸை நீங்க காப்பாற்ற முடியும். அதனாலதான் டார்ஷனை நம்ம acute management பண்ணணும். What we are going to do? We are going to acute management. So write it down. What is going to be my management protocol for acute torsion? Immediate scrotal exploration. I am going to perform immediate scrotal exploration. Okay, so I am going to perform immediate scrotal exploration. Number 1. Now, I am going to perform immediate scrotal exploration and I am going to see whether my testis is viable or not viable. Okay, so I am going to see whether my testis is viable or whether my testis is not viable. Unfortunately, testis is not viable. What are you going to do? Testis is not viable. Cut பண்ணி வெளில எடுத்துருங்க அவ்வளவுதான். So that is called as orchidectomy. So I want to perform orchidectomy. If testis is viable, now what are you going to do? Testis is viable. Now what are you going to do? You are going to perform orchidopexy. I'm not going to cut and remove it. I'm going to perform orchidopexy. Okay. So now immediate scrotal exploration பண்றீங்க. Should do orchidopexy of opposite testis after this. Okay va? So இந்த orchidopexy பண்ணி treat பண்ணதுக்கு அப்புறம் so you should also perform orchidopexy of opposite testis. So what is orchidopexy? Again, should I repeat? So you are going to do maneuvers to gain the length. Processes vaginalis is identified and separated and then ligated. Covering of spermatic cord is going to be divided. Lateral fibrous band just inside the internal ring is divided. This is called as orchidopexy. 4 point மறக்க கூடாது. Maneuvers to gain the length. Processes vaginalis should be identified and separated and ligated. Covering of spermatic cord should be divided. Lateral fibrous band just inside the internal ring should be divided. Right? Orchidectomy na removal. Now, torsion management பண்ணலாம்னு பார்க்குறீங்க. ஆனா unfortunately, the science is not perfect. Science not perfect. இப்போ என்ன பண்ணுவீங்க? ஏன்னா உங்களுக்கு வந்து you have to know the difference between epidermoarthritis, right? Epidermoarthritis அதுவும் ஒரு பக்கம் இருக்கு. How do I treat this patient? ஸோ எபிடைமோஆர்த்ரைட்டிஸ் இருந்தாலும் நீங்கள் சஸ்பெக்ட் பண்ணாலும் சரி, இல்லை டார்ஷனோட சயின்ஸ் வந்து பர்ஃபெக்டாக சிங்க் ஆகலைனாலும் சரி, யூ ஆர் கோயிங் டு கோ ஃபார் அ டியூப்ளெக்ஸ் ஸ்கேன். ஐ எம் கோயிங் டு பர்ஃபார்ம் அ டியூப்ளெக்ஸ் ஸ்கேன். ஐ எம் கோயிங் டு see whether vascularity is good. If the vascularity, if it is going to be reduced or if it is going to be absent, what I am going to do? Immediately, I am going to go for a scrotal exploration. If I have a very good vascularity, I am not having any problem in the vascularity, then definitely it is going to be epidermoarthritis. It is definitely going to be epidermoarthritis, no doubt. Okay, now epidermoarthritis. What is the problem over there? As the name suggests, itis, inflammation, epidermo. Orchitis, testis. Orchitis means testis. Epidymo means epididymis. So your epididymis and your testis is going to get infected. Who is going to infect your epididymis and testis? Who is going to get infected? Who is going to infect? Anyone? Chlamydia more than E. coli. This occurs more commonly in more than 40 years of age group. So what is going to be your management for these patients? Very easy. So how we are going to manage these patients? We are going to manage these patients by antibiotics. Antibiotics. You're going to give antibiotics for this patient. And you're also going to give scrotal support. Scrotal support. Now we have come to the end of three important discussion points, three important conditions in your testicular mass. Now, the favorite thing of all the students and favorite thing of interns also, that is hydrocele. So, hydrocele surgery, எல்லாரும் பண்ணுவோம் இன்டர்ன்ஷிப்ல ஹைட்ரோசீல் கேசஸ் காமனா நம்ம ஓபிலையும் நம்மளோட வார்ட்ஸ்லையும் பார்க்கக்கூடிய ஒரு கேஸ். ஸோ அதை தான் நம்ம பார்க்க போறோம். லெட்ஸ் சி, we are going to move to the next topic, that is hydrocele. So, do you remember we classified the entire testicular mass into three categories: absent testis, painless scrotal swelling, and acute scrotum. Remember, right? So now this comes under the heading of painless scrotal swelling. This comes to the heading of painless scrotal swelling. If you have a bigger paper, I recommend you to take it in a single paper. ஒரே பேப்பர்ல எல்லாத்தையும் எழுதி முடிச்சிடணும். அதுதான் பெர்ஃபெக்ட். நான் பண்றதே தப்பு தான் இங்க. ஏன்னா கம்பேரிசனுக்கு ஈஸியா இருக்கும் உங்களுக்கு. இன் ஆர்டர் டு ஐ டிடன்ட் ஹேவ் மை ஸ்பேஸ் ப்ராப்பர்லி. ஸோ அதனால அண்ட் ரொம்ப சின்னதாக எழுதுனா யூ கேனாட் காப்பி. ஸோ தட் இஸ் த ரீசன் வை ஐ எம் டூயிங் இட். பட் பெட்டர் நோட்ஸ் டேக்கிங் இஸ் மேக் இட் இன்டு அ சிங்கிள் பேஜ். Painless scrotal swelling. The patient is going to present to you. You are going to perform a clinical examination for the patient. And first cases, it is non-tender. On the side, non-tender. I am not going to tell what is the problem in both the side. You are going to identify along with me. So, ரெண்டு patient வந்திருக்காங்க. ரெண்டு patientக்கும் painless scrotal swelling. So, you are a surgical resident over there. And in your unit itself, you have a senior surgical resident. So, you are senior. So, both of them. Now, the faculty who is your unit chief is telling you that you go and see this case, you go and see this case. And both of them are going to compare and tell me which case is going to be hydrocele, which case is going to be a solid tumor. So let me name this person as person A and this person as person B. With this first point, non-tender, you cannot identify anything. Okay, understood, understand. So I'm leaving you. Second thing, I am able to get above the swelling. Here also I am able to get above the swelling. Here also I am able to get above the swelling. So இப்போ நான் எழுதுறது வந்து பார்த்தீங்கன்னா உங்களோட தாஸ் டெக்ஸ்ட் புக்ல இருக்கு. தாஸ் டெக்ஸ்ட் புக் எடுத்தீங்கன்னு வச்சுக்கோங்க, அழகா ஒரு டேபிள் கொடுத்துருப்போம். டிஃபரன்ஸ் பிட்வீன் யோர் சாலிட் டியூமர்ஸ் அண்ட் பினைங் ஹைட்ரோசீல் கொடுத்துருப்பான் பாருங்க. ரொம்ப சிம்பிள். அதையே தான் நான் இப்போ ரெப்ரசென்ட் பண்றேன். பட் நம்ம ரெகுலரா நம்ம கிளினிக்கல் போஸ்டிங்ஸ்லாம் எக்ஸாமினேஷன் எப்படி பண்ணுவோமோ அதே டெக்னிக்ல நம்ம போவோம். First, you are going to see whether that is going to be non-tender. Both are going to be non-tender. Then whether you are able to get above the swelling. In both A and B, you are able to get above the swelling. Third one, is it reducible? Both are non-reducible. என்ன சார் இது, ரெண்டு பேரும் ஒரே மாதிரியே ப்ரெசென்ட் பண்றாங்க. இதே மாதிரி தான் அந்த சர்ஜிக்கல் ரெசிடென்ட் ரெண்டு பேருமே பேசிக்கிறாங்க. சார் உங்களோட கேஸுக்கும் அதே தான் வருது, என் கேஸுக்கும் அதே தான் வருது. ஃபர்ஸ்ட் 3 ஃபைண்டிங் பார்த்துட்டோம் அப்படிங்கிறாங்க. ஸோ 4வது ஃபைண்டிங் பார்க்குறாங்க. Fluctuanta. So my patient A is going to have a fluctuant mass. But now comes the main player. So here I am going to have a non-fluctuant mass. I am going to have a non-fluctuant mass. Similarly, in next one, I am going to have a trans-elimination positive. Trans-elimination positive. Whereas in here, elimination test is going to be, elimination test is going to be negative. Okay, so when you're going to have such a typical case, so when there is going to be a fluctuant, trans-eliminant, non-reducible, non-tender, painless scrotal swelling, then the answer is going to be hydrocele. If you are going to have a non-fluctuant, non-eliminant, no trans-elimination, non-reducible, gets above the swelling, non-tender, painless scrotal swelling, then it is going to be solid mass. Now, very good. Give yourself a big appreciation. Now, the both of them has diagnosed the case. ஒருத்தர் ஹைட்ரோசீல்னு சொல்லிட்டாரு, இன்னொருத்தர் சாலிட் மாஸ்னு சொல்லிட்டாரு. இப்போ என்ன பண்ணுவீங்க நெக்ஸ்ட்? ஹைட்ரோசீலா இருந்தா நெக்ஸ்ட் டைரக்டா சர்ஜரி போங்க, ஒண்ணுமே தேவையில்லை. ஹைட்ரோசீலா டைரக்டா சர்ஜரிக்கு எடுங்க. You are now identified, so you can directly take for surgery. There is no problem at all. But if it is going to be a solid mass, you need to go for a USG scan. I'm going to perform USG. Okay. And in this process of taking USG, I am also going to take the level of beta HCG. I am going to take level of LDH. I am going to take the level of alpha fetoprotein. I am going to take the level of alpha fetoprotein. I am going to take the level of LDH. I am going to take the level of beta HCG. Okay. So after doing that, if you are going to get a solid tumor, you are going to perform a eye inguinal orchidectomy. I am going to perform eye inguinal orchidectomy. Okay, wow. So when I'm going to perform eye inguinal orchidectomy, so what is the procedure called as? I'll explain you, don't worry. Chivasa's procedure. I'll explain you, don't worry. So Chivasa's procedure. So now you're going to send for biopsy. I'm going to send for biopsy. And I'm going to see whether my case is going to be a seminoma or I'm going to have a non-seminomatous germ cell tumor. Non-seminomatous germ cell tumor. And after doing that, I'm going to go for CT abdomen pelvis. I'm going to go for chest X-ray. I'm going to see whether any metastasis is there. Same way, CT abdomen, you're going to take CT pelvis, I'm going to take CT thorax. So இதெல்லாம் நம்ம malignancy பார்க்குறப்ப பார்க்கலாம். Maybe probably tomorrow I'll discuss malignancy. Today I'll make sure I'll complete the hydrocele and other things. Malignancy in detail பார்ப்போம், நாளைக்கு பார்க்கலாம். ஓகேவா? So hydrocele பொறுத்த வரைக்கும் you have 3 types of surgery. One is you are going to, if you want to do a eversion of sac, you are going to do eversion of sac. You are going to perform Jaboule's technique. And in small surgeries, you're going to perform Lord's plication. If you're going to have a thicker one, you're going to go for a excision of sac. You're going to perform excision of sac. Now, have you ever thought why there is a transelimination? Can you tell me, guys? Very easy. Think. So primary vaginal hydrocele or your hydrocele, most common, it is going to be defective absorption of fluid. So you're going to have a tense swelling in which the testis is not palpable separately. So you're going to have a clear fluid and that is going to give you a transelimination. Secondary to some trauma or due to some inguinal tumors or anything also, this is possible. But இங்கே வந்து testis palpable இருக்கும். Secondary case ஆ இருந்தா testis palpable இருக்கும். So ultimately hydrocele na என்னங்க? Hydrocele na ஒண்ணுமே இல்லைங்க. Accumulation of fluid in tunica vaginalis. அவ்வளவுதாங்க. ஓகேவா? So மறக்கக்கூடாது. Accumulation of fluid in tunica vaginalis. That is going to be your vaginal hydrocele. Now, you know the treatment. You can go for Lord's plication or Jaboule's procedure, eversion of sac, or nothing is working out. You can go for a excision of the sac. Clear, right? So this is going to be hydrocele. But what happens in some people, it can be a congenital hydrocele. Congenital hydrocele எதனால வரும்? Due to the patent processes vaginalis. You're going to have this congenital hydrocele. Okay, wow. So congenital hydrocele, what will be your treatment? Your treatment is going to be surgery. Again, what is going to be your treatment? Surgery. Next, infantile. Infantile na inguinoscrotal swelling. So superficial inguinal canal இறங்கி வரும்ல அந்த இடத்துல. So you're going to just perform excision of excess sac and you're going to eversion of sac is going to be done. And you have encysted hydrocele of cord is also going to be present. So with this, I'm stopping for today. It's 45 minutes already. So I'm not going to extend your session much. So today we have discussed hydrocele. Today we have discussed the absence testis, undescended testis. And I have also discussed the preliminary management, or how we have to, we are going to proceed with a painless scrotal swelling. And torsion பார்த்துருக்கோம் நம்ம இன்னைக்கு எபிடெமோ ஆர்ச்சைட்டிஸ் பார்த்துட்டோம். இல்லை torsion 5 mark, எபிடெமோ ஆர்ச்சைட்டிஸ் 5 mark. So you have your Anderson testis, which is asked as a 5 mark question. Okay, so tomorrow, that is going to be your, what is the date tomorrow, guys? Today is 2nd May. So tomorrow, 3rd May 2000, so 3rd April, May 2024. What we are going to do? We are going to go with the next topic. I'll give you a clue today itself and clue. So what we are going to discuss tomorrow is 28-year-old or male abdomen, or male coming to you with a lump in abdomen at epigastric region. So this is how the patient is going to come to you. Now you're going to write down what are the possible diagnosis I can arrive from this 28-year-old male lump in the abdomen at epigastric region. I'll be checking you out tomorrow. So with that, I'm completing today's session. Tomorrow, we will be starting at again 9:30. So where we will start with varicocele. We will go with the testicular tumors, seminoma, the recent TNM staging. Then I'll go for the treatment of all the seminomatous and non-seminomatous tumors. And I'll end with one important 5 mark tomorrow, that is Fournier's gangrene. With that, the entire genito-urinary system is over, guys. We already completed genital or urinary system. Now we are in the genital system, and you won't remember, you won't recall. So we have actually completed everything except your bladder cancer. bladder cancer, prostate cancer மட்டும்தான் பார்க்கல, BPH பார்க்கல. அதை நான் வந்து தனியா I will cover it as a BPH வந்து தனியா I will cover it by next session. So tomorrow we are going to have one session. Saturday we are going to have one session, and Sunday we are going to have thyroid case presentation, right? We have. Okay, wow. So don't worry. So all the best. Do prepare in an everyday basis. Daily one topic. You won't believe me. At the end of the year, you will be like the one of the happiest person among all your batchmates if you're going to do this along with me. Okay, that is the reason why I am taking efforts and doing for you guys. So see you all tomorrow. Thank you.